Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausmann. Show notes for this episode can be found at acronair.org. You can find our previous episodes on Apple Podcast, Spotify, Google Podcast, and on your favorite podcast app. ACR Convergence 2022 started with Dr. Adam Verghese talking about stories and how we can view the COVID-19 pandemic as a monster story. The story of our lives, he called it. I think he's right on. A horror story of epic proportions and whose end hasn't yet been written. But now that Convergence 22 is over, we wanted to reflect and tell stories about how Convergence impacted us, what we learned, what challenges we faced, and how we overcame them. We invited Dr. Alfred Kim to share his insights about Convergence 2022. Those of you that have listened to our podcast previously may recognize him from episode 33 on B-cell depleting therapies and COVID-19. If you haven't heard that episode, I would strongly encourage you to do so. Dr. Kim is Assistant Professor of Medicine and Assistant Professor of Pathology and Immunology at Washington University School of Medicine in St. Louis. He's a rheumatologist at Barnes-Jewish Hospital. He founded and currently directs the Washington University Lupus Clinic and engages in both clinical care of patients with lupus and heads a large research program related to lupus erythematosus. And he's also been intimately involved in COVID-19 research among patients who take immunosuppressive drugs for autoimmune diseases. In today's episode, Al and I will tell stories about the highlights of Convergence 2022, including the positive impact of this in-person meeting versus previous virtual meetings. We'll discuss challenges that we faced during Convergence and why we were all so exhausted at the end of the meeting. Al and I highlight some of our favorite sessions and themes that arose from Convergence. We also discuss how the research presented at this year's meeting may have great impacts in how we diagnose and treat our patients in the future. Enjoy. Al, welcome to the show.
Well,
Again.
thank you so much, Jonathan. I feel like this is becoming a regular occurrence between the two of us.
It definitely should be. We can have, a segment, talking points with Al or something like that.
Yeah. That would be certainly a multi-part segment for sure. Yes.
So Convergence 2022 is done. Can you believe it? The first time it's been in person in a couple of years.
Yeah.
What did you think about it? We were actually in person. We were in Philly.
Yeah. So it was so good to be able to see everyone again in person, including you. The networking is just so much more efficient, and I think this is the one thing we kind of knew coming out of COVID's most intense period was that the Zoom interfacing was effective to be able to just get conversations started. But I think to be able to discuss nuances on the fly, it was really difficult. So it was great to be able to network, to be able to see the collaborators once again, really actually get some important progress done intellectually on a lot of the projects that we were working on. And frankly, it was just super therapeutic to see people, your colleagues again.
Yeah, I totally agree with you. And I think it's those, at least for me, it was those chance encounters of people that I hadn't seen, in several years, just meeting them, down the hall as we were walking to different sessions. So great to catch up with people and hear about what they're doing and what their projects are and family life and everything. I mean, it's sort of the human side of rheumatology that I think it's much more difficult to convey through meetings through Zoom.
Right, absolutely. And I know this discussion is going to be very free flowing, so I think the one thing we can flow to is actually kind of the ideas of how most of these abstracts are presented. It's a hard format to be able to to be able to pull off, and I think Sharon deserves a ton of credit for being able to do what she did, along with the planning committee. But this was the first topic of discussion. I think Len Calabrese was one of the first to bring it up, and then Doug White later tweeted about the fact that the poster sessions really need to be in person,
Aha.
and these abstracts absolutely need, the interfacing that happens on the poster floor is immeasurable in terms of the networking and ideas that are generated. And it just didn't work virtually this year for me.
Yeah, I totally agree with you. I mean, one of the things I really missed was just, walking down the hall, those long hallways, and, looking at the posters and chatting up with people about new ideas that they're doing and thinking about collaborations. It was much more difficult, finding the posters online and then clicking the button to hear the 5 minute audio,
Right.
and sort of that lack of interaction was
Yeah. I mean,
difficult.
you just miss a ton of information. The ability to walk down one aisle and scan through 100 abstracts just by title and maybe a bit of the, kind of the introduction, just to see if it gauges, sparks your interest. um yeah, you don't really get that. You don't have that turnover, that throughput, virtually, unfortunately. So that's something that I'm super eager to be able to have restart.
Yeah, I totally agree with you. And the sessions were great. I think also, I like the idea of sessions being both virtual and in person. I think there was great interaction between people that were in the audience asking questions, and then people that were also attending the sessions virtually, asking questions. So some of those like main sessions, I thought can do well, both in person and virtual. But yeah, the poster session and sort of the networking and the interaction between people sort of are things that can only be done in person.
Yeah, it'll be interesting to see how like this all progresses. I mean, obviously, ULAR this year is going to be all in person, and I know last year's ACR, 2021, Dave Karp was telling us that the cost of a hybrid meeting is actually really built in, like the first 100 people for each platform. Expanding from 100 to 10,000 actually really doesn't cost that much more. It's just getting that infrastructure set up. So I can see why ULAR made the decision that it did, but I think there were a lot of patient advocacy groups at ACR that were concerned about the fact that most of us really weren't masking at the meeting, right? And I'm guilty as charged. I didn't. But I know that there were comments made on Twitter about it's not, the journey's not over for them, and that's 100% true.
Yeah.
And so how we move forward with all of this is it's complicated. um and it'll be interesting, again, what innovative solutions will come out of the planning committee in order to figure out, like, how do we make the meeting more accessible, particularly for our international attendees,
Yep.
i.e. virtual, but maintain the networking and the interactions that are required for a field like ours, and making sure that the in-person experience is as good.
Good point, Al. Great. So let's start a little bit about sort of any pre-meeting courses. I know, I can tell you a couple of courses that I attended that I thought were really great. So I attended the Global Health Summit, which is the second year that they're doing this. So thinking more about global rheumatology and having guests and participation from all around the world. This session was focused on sort of the effects of climate change, conflict, migration, and how it can affect health. I thought it was really interesting. I mean, they brought in people from the United Nations, from Doctors Without Borders, faculty that from developing countries that study climate change, and sort of it really highlighted how climate change can really affect populations, especially in developing nations, and both how it can affect them physically and mentally as well. Uh, One of the talks from a doctor from Doctors Without Borders talked about the high levels of anxiety, depression, and grief that were present in patients that that experience climate change and climate related violence and displacement and how to address some of those needs. So it really brought about, these brought to life, all of these issues that we're all struggling with, right? Like how to address climate change and sort of put it into a perspective about health and rheumatology that I thought was really unique. And then the other thing that I was really impressed by is that um, they brought in cases, again, that people submitted from all over the world and had experts sort of discuss the cases and give some recommendations. And that's a series that the Global Health group from the ACR has been doing and will continue to do, even, in between ACR annual meetings. So, I think they're doing really great work. And I was really happy to see that again at
Yeah.
this year's meeting.
I mean, yeah. So I missed that pre-meeting course, and I guess the question I have is as dynamic as climate change is on in terms of its impact on health. Being able to anticipate. I think a lot of the stuff we're doing maybe is reflexive right now.
Mm.
Um, I'm curious if there was any discussion about like how do we anticipate be able to mitigate in advance, some of the issues. This is obviously well outside of my field. This is
Yeah.
the number of variables that you would have to consider is overwhelming to me. So this is
Hmm.
a really hard question for me to wrap my brain around.
Yeah, yeah, and I think, Al, not just for you, but for everybody. Everybody there was sort of, you know, we know we have to do something, and there's certainly some guidelines as how to reduce emissions and things like that. But sort of clear, I don't know that people outlined like a clear pathway, like
Mhm.
this is the way to go. It's
Yeah.
still very difficult. And then the other pre-meeting course I attended was the review course, which is always great. Um, I think at least the highlight for me was seeing Dan Kastner from the NIH talk about autoinflammatory diseases. First, I was sort of surprised that it made it to the review course. So I think people are realizing that autoinflammatory diseases are important, and certainly maybe becoming more important now with the discovery of Vexus.
Mhm.
Um, he sort of reviewed about, familial Mediterranean fever and CAPS and other monogenic autoinflammatory diseases, and then ended his talk about Vexus, which is this really interesting disorder where you have systemic inflammation and patients can present with manifestations of relapsing polychondritis or giant cell arteritis, and then have um, um, anemia or myelodysplastic syndrome or something in the marrow, and it's because of this acquired mutation. And I love the way that he says the name of the disease. He always says Vexus,
Yeah.
and makes a really big emphasis on it. But
So dramatic.
I think it may be that this is the most, or will be the most common autoinflammatory disease that presents in adults. I think it's been under recognized
Mhm.
for a lot of years, and now with his work and the work of others that have sort of addressed um, all the various different ways that it presents. I think it's going to become more and more common over
Yeah,
time.
absolutely. No, I agree. It'll be interesting. I know that internally here at WashU, we are going to be looking back and seeing how many people would potentially classify a little bit more as a Vexus phenotype as opposed to anything
Yeah.
else.
Yep.
We're probably going to be very surprised, like many other people.
Yep.
Yeah.
And then we get to the main event.
Yeah.
Al, what do you think? You were there the first day.
Yeah. So I think I first want to give my very good friend Michelle Kallenberg a huge congratulations for winning the being awarded the Harry Kunkel Early Career Investigator Award. It's so well deserved, the work that she's doing, trying to unlock the link between ultraviolet light sensitivity and skin, and then eventual systemic lupus flares is, that the story she's building is really remarkable, and I think she deserves all the credit that this particular award affords her. So with that, though, I did host the COVID-19 Community Hub. I think it was interesting. In terms of an idea that could potentially work in the future are these community hubs, but again, they were all virtual this year, and it actually kind of it disrupted my ACR schedule substantially. We ended up deciding to do a lot of our meetings in the early afternoons just because of
Mm.
timing. And so I missed a fair number of sessions, meetings, and so it'll be, and also since everything was virtual, even though all the attendees were there in person, we did lose some aspects of communication. So it'll be interesting, like as this carries forward, whether or not we could literally get a room, and have more of a conversational
Yeah.
arrangement. Obviously there'll
Yeah.
be moderators invited people, but even people in the audience who can participate and ask questions a little more freely without intimidation. That's again the hardest part. I think there is a way it can work moving forward. It's just how does that format look like? But I think in terms of the COVID-19 Community Hub, I think the two main themes that kept on coming up was first long COVID, and that was one of the first things we actually opened up the hub with was with Len Calabrese, um, essentially providing a 15-minute soliloquy on what his perspectives on long COVID. And I think there are
Aha.
a lot of people that have thought about long COVID in rheumatology, but I think he's put the most thought into it in terms of not only trying to define it. It's more than just having prolonged COVID symptoms, but it's certainly, there's a resolution of these symptoms, but there's these residual, what you can call more subjective type symptoms, kind of the
Mhm.
cognitive dysfunction and fatigue, and primarily that ends up being um, very easy to dismiss. And I think this is a really important point that Len brought up, was that we have to, similar to all of our diseases, where the diagnosis is essentially a signs and symptoms type of thing, as opposed to a more objective, say, laboratory diagnosis. Validation of symptoms is absolutely critical for these patients. And I think, in lupus, we've run into this problem too of the lack of validation symptoms and lack of then social support, which then
Mhm.
erodes quality of life. We don't want to be able to fall into that trap with people with long COVID, even though their symptoms tend to be so mysterious, subjective, and difficult to identify root cause, because we don't fully understand the immunology
Yeah.
of long COVID or the mechanism, right? It could be more than immunologic.
Yeah.
He really did spend a long time making sure that the people in the hub, uh, you know, recognizes it, acknowledges it, works with the patient to be able to at least, think about other alternative ways to be able to, think, to diagnose these people. Although you usually end up with long COVID at the end of the day, and then give them support to be able to say, we're all thinking about this, working on this, and making sure that they have, again, the healthcare team on their side. So I think Len really did a great job of describing all of that. And then I think the second theme that was brought up was, again, the future of COVID for our immunosuppressed patients. And I think this is challenging, especially since these new Omicron subvariants that harbor this arginine 346X mutation. It's clear that there is this convergence of subvariants in Omicron that are really trying to evade current immune responses, whether it's post-infection or post-vaccination, and it's really kind of bottlenecked Omicron into kind of these newer subvariants. The names are obviously crazy, like BA.4.6, BQ.1.1, BX. Yes, but all of these are highly evasive. The new bivalent vaccines can certainly help, and they probably will help a lot for the majority of immunosuppressed people, much like the original mRNA vaccines for the majority of immunosuppressed people. But again, it's going to be our B cell depleted people, those on mycophenolate, particularly on polytherapies, potentially those on high dose steroids, and maybe even JAK inhibitors. These have much more diverse and generally lower immune responses post vaccination. And so the issue then becomes whether or not we have any ways to be able to mitigate that, and that usually is Evusheld, right, or tixagevimab and silgevimab. Although now the newer variants occupy the vast majority of the circulating variants right now, based off of the CDC website. So, tixagevimab and silgevimab have been rendered essentially unusable at this time, and obviously bebtelovimab, which was used for post-exposure use, has been the EUA has been rescinded by the FDA because it doesn't work anymore either. I do know, though, that AstraZeneca does have a newer version of, quote unquote, Evusheld 2.0 under development under the name of AZD 5156. Essentially, it's silgevimab that's maintained, but tixagevimab has been removed, and there's a new monoclonal antibody that's been introduced. And so this can actually neutralize all of these new emerging Omicron subvariants. Again, this is under development. It's clinical trials are just starting up internationally, including in the U.S. And so once those trials are completed and the um, data and is be able to review, especially safety by the FDA, then we expect this to be able to roll out. How quickly, though, is a really great question, and I think this is going to be an issue of how, if we can get this out before any additional subvariants emerge, then that's obviously the win for our patients. But again, because a trial is being mandated by the FDA, we have to be able to follow the rigors of that and then generate the data to be able to make a decision of whether or not it's safe, and certainly whether it's effective.
Yeah, Al, just yesterday, one of my patients who was on rituximab sent me an email saying that she had developed COVID. So certainly COVID for these B cell depleted patients, is still a big issue, and hopefully we
Yeah.
can get some better therapies going
Right. And
forward.
again, with the loss of efficacy of the current monoclonal, pre-exposure prophylactic antibodies, and the vaccination really still is that key. And again, there's emerging data. Some of it was presented at ACR. Most of it is published now. That again, there's a 6-month waiting period post B cell depletion therapy administration that seems to be critical in order to be able to then vaccinate afterwards and then generate responses. Again, similar to the influenza vaccine experience.
Yeah, yeah. Another thing I agree with you about your comment about these community hubs. So I took part in the education community hub, and it was really strange because, all of the presenters were in the same room, but we were all in these like individual desks that were covered with curtains so that we couldn't see or hear each other. And yet we were sort of trying to interact online, which was very odd. And I agree, it sort of set you away from the convergence meetings to host this sort of virtual symposium.
Right.
So I agree. If we could do it, the community hub idea is great, but if we could do it in person so that we could actually interact with the other presenters and interact with the audience, I think that might be a little bit better.
Yeah, I guess just to find to wrap up on this thought, that for me, actually, I had set up essentially a studio in my hotel room, right? Because I think, for those who don't really do a lot of recordings, the equipment isn't that important. But for those that do, like, we are very picky about our equipment. Like, I have this Blue Yeti microphone that I actually brought to Philly to make
Wow.
sure, right? And then I set up the lighting and everything. In my room, but again, it required me to go to the room because I think there weren't really formal studios for these hubs. And again, this is kind of all how we will this concept will evolve in the future. But I definitely was considering all of that, but again, it pulled me away from the convention
That's
center
right.
back to my hotel room. Then I had to go back, right? Yeah, so again, it'll work out in the future, but just how we execute it and re-envision how this works is going to be important.
Totally. And Al, I'm pretty sure you ventured into at least a couple of lupus sections. Can you
Yeah, I
talk
don't
a little
know.
bit about
Yeah, I don't know
about
anything about lupus. No, I'm kidding.
Did you
Yeah,
learn anything? Did you hear
yeah.
anything interesting?
Yeah, so obviously, Jörg Schett's, CAR T cells,
Yeah,
against CD19 has generated a buzz in lupus that I've, in my very short career, I've never seen before. Just to catch everyone up, Jorg in Erlangen, Germany, has done some really interesting work using CAR T therapies that end up binding and eliminating CD19 positive cells, which are the majority of your B cells. Um, and he published a case report on this back last year in the New England Journal of Medicine, and then about a month or month and a half ago, I had a really nice Nature Medicine paper on the first 5 patients that he has treated. And I think what's really fascinating, and that is encapsulated by the very first patient that was given this therapy, was that these are people with high disease activity despite multiple interventions, and essentially they what we would call are treatment resistant. So this first patient, she was on hydroxychloroquine, high dose glucocorticoids, mycophenolate, rituximab, belimumab, FK506, and actually was on some of those right before entering the study, was given CAR T therapy to CD19, and is now over 600 days out with no disease activity, no interim flares, and is actually on no meds.
that is
Yeah,
unbelievable.
right. And so this N of one experience, and I said this in the closing session, right? That antidote is not data, and plural antidote is still not data, right? It's just the biases, recall biases, all these things is is overwhelming. But this is really fascinating. And I think in Jorg's paper, what was the most interesting piece of immunologic data was that even though the B cells came back in 3 to 4 months, most of them were IgM bearing. So, in other words, those are going to be essentially your naive B cells. They have not been activated. They have certainly not class switched. And it makes this particularly interesting argument that, are we resetting B cell tolerance? And is this phenomenon durable? Right. And is that part of the reason why this is working? And I don't, there's going to be a lot of work being done. I know there's at least a couple efforts that are being pushed forward in terms of clinical trials for these, treatment resistant lupus patients globally. It'll be fascinating to see whether or not this ends up being um, a reasonable therapeutic option despite its potentially very high cost. So time will tell. But again, the concerns of like cytokine release syndrome and that you typically see with CAR T therapies in tumors wasn't really experienced at that same level, largely because I think we have way fewer B cells that we're targeting compared to tumor cells. And so the cell that you're targeting, the more there are, the more likely you'll have this cytokine release syndrome, which is an issue. So again, I'm fascinated by this entire thing, and I know Max Koenig also had a plenary talk looking at a slightly different concept. Instead of targeting CD19, he actually was presenting proof of concept data at the preclinical level of these chimeric autoantigen T cell receptor T cell therapies, CAR T cell therapies, essentially, that ends up, in his case, trying to target antiphospholipid syndrome antigens. So, this field's going to be absolutely. Um, it's there's so much work that's going to be done in this. So similar to how we were able to galvanize with, say, COVID-19, I think there's a similar enthusiasm for CAR Ts generally in autoimmunity. So I think there's going to be a lot of interesting data that will come out in the next 3 to 5 years in this.
Yeah, I also, heard about Max Koenig's sort of approach for antiphospholipid syndrome, and the idea to selectively kill just the cells that are producing the autoantibodies is so interesting. So instead of doing these sort of broad immunosuppressive drugs, just targeting the cells that are the problem
Hmm.
selectively
Hmm.
is so interesting.
Yeah. So the only caveat with this approach, and we talked to Max about this afterwards, was that so essentially what he's doing is he's expressing the autoantigen on the chimeric T cell receptor. And so as a result, if it engages the B cell receptor, which would be the autoreactive B cell, gets destroyed. So you can selectively deplete out your autoreactive B cells. But there's a theoretical risk here if the autoantigen actually binds to its cognate receptor, So you
Mm.
have to be very careful about which autoantigens you express, because you can actually destroy your own tissue
Uh,
in this particular situation. So
uh,
again, I think the concept needs to be tested. We'll worry about trying to mitigate, how we can, reduce, risk later on. But again, all of these ideas just need to be able to, kind of, incubate, explore themselves, and then we'll figure out at the end of the day, what ends up working. But again, it's a really interesting way to be able to do this, and this was actually done before, to a certain extent, with several investigators at Penn. So this idea, the proof of principle is out there. So again, it's very exciting to see its application within autoimmunity.
Great. Are there other things that you thought were interesting, either
Yeah.
lupus or other
Yeah, so
conditions?
I think the other thing, lupus nephritis is something we are very, um, you, the problem with lupus nephritis is we have to get tissue, right? That establishes the diagnosis, and patients don't like to get biopsies. It's pretty clear. So I've been following the work that Andre Fava has been doing at Hopkins, along with the Accelerating Medicine Partnerships effort, the AMPS effort. And I think the story he's building with urinary biomarkers has been really interesting. Um, the probably the one that's most advanced is urinary IL-16. This came out in the publication Arthritis Rheumatology earlier this year. And I think what's really fascinating about this particular cytokine is that it correlates really well with proliferative lupus nephritis, which is obviously the most feared histopathologic subtype of lupus nephritis. It is actually the second highest expressed cytokine by infiltrating immune cells in the kidney. And so there's a correlation between the acquisition of inflammatory infiltrates with this particular cytokine. And on top of that, the cytokine is expressed in probably the two most vulnerable areas of the kidneys in lupus nephritis, which is going to be the glomeruli, and then the tubular interstitium. And so I misspoke in the closing session, saying that I wasn't, that this wasn't validated, but he immediately corrected this in real time on the chat. And yeah, I want to thank Andrea for emailing me the other information afterwards. This particular cytokine in the urine has been validated in two independent AMP ancestrally diverse U.S. cohorts, and also the Karolinska group also confirmed this in 100 Swedish patients. So this particular marker has a lot of legs to it, and I know that they're working on trying to figure out how to commercialize this so that we can get this into, say, clinical trials, because the lupus nephritis clinical trials are starting to explode in a variety of mechanisms, and also potentially for its use in, at least initially, identifying those that need urgent biopsy, right? And so this is a non-invasive way to be able to assess specifically the worst pathology in lupus nephritis with worst clinical outcomes. This is really important. And then again, there are a couple other markers that he also discussed. Urinary CD163, which was actually originally previously identified by Brad Rove in Ohio State, and then also urinary CD206. Both of those actually have really amazing response kinetics. In other words, if people get treated and they do respond, these markers drop like a rock in the urine. For those people who are more statistically bent, the receiver operator characteristics area under the curve is greater than zero point 0.9, which is really impressive.
Mm.
1 is the best. 0.5 is pretty much useless. That's like flipping a coin. So this is really impressive. Never seen before in lupus nephritis. So again, I think the stuff that they've been doing with AMP generally has been super influential, both for RA and for lupus, but specifically for me, being able to try to identify patients that really need a biopsy, and even maybe convince nephrologists that maybe the person they may have underestimated the need for biopsy. This really allows you, at least in that initial level, to be able to say, okay, I need to triage this person higher. So
Got
that's
it.
really important to me.
So at this point, it doesn't seem that it can obviate the need for a biopsy. It's not like a liquid biopsy, but this may help you identify those patients that are at highest risk for nephritis, and then getting them to nephrology to get a biopsy?
Yeah, so I think we've defined the floor and the ceiling of this. The floor is that it triages people for biopsy. The
Hmm.
ceiling is that it could potentially replace the biopsy, right?
Got
So
it.
again, time will tell, and obviously the answer probably lies in the middle. But time will tell whether or not how specific this is. Obviously, as a screening tool, you do want it to kind of overcall the number of people with proliferative LN. But if you're going to use this independently as a tool um, to diagnose proliferative LN, now you're introducing potential harm, right, to those people that may not actually have proliferative LN, but have, say, elevated urinary IL-16. So again,
Yep.
we'll see over time and see how all of this kind of wraps, how the story kind of defines itself.
Yeah, that's awesome. It's been, yeah, great to see the advances of diagnostics and monitoring of these patients.
Mhm.
I can tell you one of the presentations that I thought was really interesting, going now to pediatrics, was the result of the Stop JIA trial. So for those of you that don't know, this was a very large trial done by CARA, which is the Childhood Arthritis and Rheumatology Research Alliance, on patients with polyarticular JIA. And it really asked a question that I ask myself every time that I see a patient with either JIA or rheumatoid arthritis or psoriatic arthritis, which is, what is the best medication to use at disease onset, right? Is it better to just start them on methotrexate, see how they do, and then do step up therapy, meaning if methotrexate monotherapy doesn't work, then add a biologic later? Is it better to just start with a biologic first? Or is it better to do what they called early combination therapy, which is methotrexate plus a biologic? And they followed, these kids now, I think, out 2 years. And, while there weren't significant differences at 12 months, at 2 years, those that started on early combination therapy, meaning methotrexate or, conventional synthetic DMARD plus a biologic, actually were much more likely to have clinically inactive disease as compared to those that received just biologics first or those that received step up therapy. So, it tells you if you're more aggressive initially when treating patients with JIA, and this may expand to other inflammatory arthritides, maybe you have a better ability of capturing them and keeping them in remission as compared to sort of delaying therapy. What are your thoughts?
That's really interesting because I think in lupus nephritis, for example, we're starting to change our paradigm towards that. I think,
Huh.
Maria Del Ara really presented this at last year's Snowmass meeting, and I borrow this slide with her permission in every lupus nephritis talk I give because essentially I think in the past we had stuck with kind of like glucocorticoids, mycophenolate versus cyclophosphamide, and then we kind of play around after that. Whereas now, I think the idea, especially because we have other therapeutics out there, maybe we need to start combining them, right?
Mm.
Hit it as hard as we can right at the beginning, because this will reduce glucocorticoid burden overall downstream, get some remission earlier. I think these data are really instructive regarding that. I think it also makes me think about the data from the Stop RA trial,
Mm.
which just used hydroxychloroquine in the CCP positive, but not. They just have arthralgias. They certainly don't classify for RA. And there they did not find any difference between those that were on hydroxychloroquine versus not. And again, when do you treat with high intensity therapies to be able to mitigate is a really interesting question. It's going to be it's going to be intensity of immunosuppression versus time before acquisition of certain symptoms. This equation is going to be really interesting to solve. It's going to require, I think, all of our careers for each of our diseases to be able to define. But I think that Stop JIA is provides again that clinical proof of principle that the earlier we really have to be way more aggressive earlier, right?
Yeah.
And this the short term is going to be potentially a little rough for the patient, and this is where having enough support is going to be really critical for these type of patients. But once you get through that initial part, you really are reaping a lot of benefit downstream.
Yeah. I think this made me think of um, another article that we presented on this podcast about the early use of biologics for people with systemic JIA or Still's disease. That they showed that, if you treat them aggressively with biologics first, you can usually get them in remission and even off medications at the end of a year. And compared to historical cohorts that were treated with steroids primarily, they had disease. Many of those patients went on to have chronic disease with systemic JIA, whereas those that were treated early with biologic, were into remission and off drugs after a year. So maybe there's this window of opportunity that, if we treat aggressively early on, we can actually, provide a significant, lifetime benefit
Yeah.
for patients with autoimmune diseases.
Yeah, that's so exciting though, right? Again, you think about the people that trained and were practicing rheumatology before we hit training, right? You talk to some of the senior rheumatologists and like, oh, methotrexate was amazing when it came out, right? And but again, I think this is the credit to both the rheumatology community, but also our industry partners, right? They really took an interest in trying to make sure that these diseases, even though they're uncommon, they have the patients have a substantial quality of life burden for sure. And they also they're expensive diseases, because of hospitalizations, ER visits, just healthcare utilization. So entire idea of being able to develop tools that are allows us to be able to do this type of work has been really important. So again, it's going to be really interesting to see how this moves forward.
Yeah. And Al, did you listen to the talk about how copays influence treatment adherence for patients with lupus?
Yeah, that yeah, I think that's really anecdotally we noticed the same thing,
Huh.
that but they were able to define it at kind of a $10 copay, which we didn't really exactly assess. But it does make a lot of sense that again there are multiple barriers for medication and adherence in our lupus patients. And we've even looked, just for to catch everyone up. Basically, if you say hydroxychloroquine blood levels as a surrogate for medication adherence, um, the majority of our lupus patients in most centers are partially adherent or non-adherent. And it's the disparity issues here are complicated, but certainly one of the equations here is certainly going to be cost. And again, that was presented at ACR, and then we've also looked internally at my own patients,
Oh,
where reasons for intentional medication non-adherence, and it actually ends up being poor provider patient communication streams. And so that it's interesting when you publish data on your own cohort ends up being a lot of your own patients, and when you're asking important questions and you end up thinking, my gosh, I'm actually not a great doctor.
yeah.
So it actually really highlighted how I'm not really doing a great job of establishing these communication streams the way I need to with my expectations, and certainly not aligning it with the expectations of my patients. So again, I think it's multifactorial, but certainly cost ends up being a substantial issue. And I think these data, I would love to see the data once it gets published and really break it down, because I think this is a really important point.
Yeah, I think one of the things that struck me as really interesting is that household income didn't really play a role in adherence and copays. You would think, well, people that make more money
Absolutely.
would just be more willing to pay and adhere to those medicines, but it seems like it applies throughout the board, regardless of your income.
Right, right. In a weird way, it's kind of like when you go to an app store for your phone, and you're like, "I'm not paying $4.99 for this app." All right,
That's right.
it has to be less than $1 or free, right?
Yeah.
So even in many other realms, we think very similarly, right? And so it'll be this is really interesting.
Yeah, and it's interesting, just thinking about how insurance companies, are responsible for premium costs,
Mhm.
and if they think that, patients may have better adherence and therefore lower lifetime costs, maybe reducing copays or eliminating them might be a way of improving outcomes
Yeah, I mean,
and decreasing costs
right,
overall.
exactly. I mean, all you need to do is look at Dr. Glaucoma Flecken's tirade on pharmacy benefit managers just to get an idea of the barriers that we have within our system.
Oh
So
my goodness.
anyway,
We
with
should
that,
definitely put links to
yes,
all of his videos
yes,
on our
100%.
website at acronair.org because I
Yeah,
agree they are hilarious and very true.
very true, very pointed. I mean, he there's no fluff, and that the clarity of his message is really important.
Yep. Other things that struck you or things that you found interesting?
Yeah, so I think the last thing I'll bring up was that this is the first ACR where I left absolutely exhausted. Um, And I don't know. I think part of it to me was also that I think ACR this year was shorter by about a
it
day and a
it
half.
definitely was shorter, yeah.
Yeah, and so I understand. I mean, the stakeholders that come to Convergence are diverse. But if you really had to over categorize and overbin them, they really come in two different flavors in my mind. There are these clinicians that are trying to use the convergence to enhance their competency, right? Gain additional clinical knowledge, stay contemporized on newer ideas. And then there is a different group of people, probably morely in the educational research realm, that are really looking at this as opportunities to be able to network, build collaborations, see new data that hasn't been published yet. And so I think for me, it was also confounded by the fact that there is so much additional interest in lupus. So I had a lot more discussions with industry partners about how these trials should be run, how should we be thinking about biomarkers, et cetera. But having all of that in an extra compressed time frame
Yeah.
left me with very little recovery time during the meeting. And I wouldn't say I left the meeting defeated, but I was utterly exhausted. I think maybe the way we do the sessions for ACR, kind of we're able to accommodate both of those, right? That there's kind of a subset of ACR that is shorter, that it allows for people to only spend, say, a Friday, Saturday, Sunday, the clinicians, so they can get back and see patients on Monday, where there's kind of a more expanded version for those people, say, an academic researcher or in education, that allows you to be able to really build and follow up on ideas that and new collaborators in order to be able to get the things we want to get done. So that's kind of like my final thought. It took me a good week to kind of re-equilibrate after ACR.
Yeah, I totally agree. I mean, I think there were sessions like at 6 and even 7:30 at night after, starting at like 7 in the morning. So yeah, they tried, to compress everything into fewer days. And yeah, and I think also as a result, I think I found it more challenging to go to the sessions that I wanted to go to because yeah, I think there were more overlaps. And I think also, as you mentioned, the community hubs also sort of took away from the time at the meeting.
Right.
But yeah, I mean, I think overall it was a great meeting.
Mhm.
I do have to acknowledge the Knowledge Bowl was fantastic. It was
Mhm.
great having it,
Yeah.
in person again. I think the ACR and the Knowledge Bowl team did a fantastic job. And all the teams that were participating, they did a fantastic job. And for me, that's always been a highlight of ACR and, seeing, the future of rheumatology, there in that room, playing this great, fantastic game. I
Yeah.
thought that was really, really awesome.
100% agree. And congratulations to the MGH crew for
Yep,
taking
yeah,
home
they,
the
they
prize.
did they did
Yeah.
amazing. Great. Any last thoughts, Al? I mean,
No, I'm
I
looking
think
forward to next year's ACR already. I think there will be changes to be able to make it a little bit more familiar to us. Like the poster sessions coming back in person, I think it will be really important. Um, but yeah, I mean, again, it's renewed my enthusiasm in a different way than what we had during COVID. And I'm just I'm thrilled that this format is has endured, right, despite the fact that we had to make all these changes. So again, congratulations to the ACR planning committee for being able to pull off this year a very, very complicated structure for the meeting. But I mean, other than the fact that I was exhausted, it was thoroughly enjoyable for me.
that's right. And maybe for next year you could be the chair of the planning committee for Convergence
Yeah,
2023. You have so
you
many
know,
great ideas, Al.
well, you know what? I'm better. I guess I'm better at complaining than solving problems. So,
Well, this has been a great conversation, Al. Always great to catch up with you. And like I mentioned at the beginning, we should do this as a recurring, talk with Al session,
yeah, I'd be more
every
than
few
happy to
months.
do that. But again, thank you for the invite, and the pleasure was all mine.
Great, Al. Have a great day.
All right, take care.
So those are the stories that Al and I created from Convergence 2022. I'm definitely excited to see the publications that come out of the works presented so that I can learn more about them and see how the various diagnostics or treatments work among larger patient populations. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find all of our show notes and previous episodes at acronair.org, Apple Podcast, Google Podcast, Spotify, and on your favorite podcast app. Until next time, please keep telling stories, and of course, stay healthy.